All right. Hello, everyone. Happy Tuesday. Welcome to a special Ravi and CP Solvers team VMR. I'm so excited for today because I get the privilege of co-discussing with Ravi. And I always love co-discussing with him and just love VMRs in general. And we have a special case presenter today, Navpreet. So excited that you're presenting a case. And I believe that you presented a case through the case review committee. Is that right, Navpreet?
Yes.
Amazing. Could you introduce yourself and talk a little bit about how your experience was with the case review committee?
Yeah. Thank you. Thank you for a great introduction. My name is Navpreet Singh. I'm from India, Punjab. I'm a medical graduate from Gyan Sagar Medical College, and this is my first time presenting case at CP Solvers. Really excited to be here, and it was a great learning opportunity. So looking forward for the day today.
So exciting. This is your first time presenting. I hope it is the first of many, of hundreds of cases that you present.
So looking for that.
Awesome. How are you doing, Ravi?
Oh, I'm doing great. I'm just very excited and so happy you agreed to discuss today. And it just harkens back to when we started. I was reflecting on when we started uh, participating in VMR and discussing, and it was kind of nerve-wracking because you never know what to expect. So I don't know what NAFPRE has in store for us today, but I just feel happy because you're by my side discussing, and together we should be able to come up with some sort of a solution for
Yeah.
the case. So very, very excited and privileged to be with you today, and so great to have you back on Tuesday VMR.
I feel the same way, Ravi. We'll figure out something to say. All right, and thank you so much for Ashutosh for scribing today. And Navpreet, whenever you're ready, you can give us the first aliquot.
Okay, so let's start. Okay, so aliquot one, the chief complaint, we have a 50-year-old female who present to the ER with a complaint of numbness and tingling sensation in the left hand and left feet for 1 day. That's our chief complaint. I'll pause here for me.
All right, so 50-year-old female, numbness and tingling in the left hand and the left foot for 1 day. Um, all
Yes.
right. So this is an interesting complaint. So a 50-year-old female. So some of the things that stand out to me is that this is a sensory complaint. So I'm translating this to, is there some type of neuropathy that's happening here? And whenever I think of neuropathy or a sensory complaint, I try to localize it because just like any type of neurologic complaint, Dr. Aaron Berkowitz has talked about, we want to focus on the localization and the time course. And the time course is easier here because it's 1 day, so this is acute. But the localization, I think, is an interesting thing to think about here. So for a sensory complaint, you want to think about, well, what do kind of the peripheral nerves do, basically? So sensory information is carried from the environment to the brain along the sensory pathway. And really, I think any part along that pathway, if there's a lesion there, can result in numbness and tingling. So is this a peripheral nerve? Is this a plexus issue? Is this a nerve root issue? And I think another important thing to think about when you have peripheral neuropathy is how many nerves are involved. So is this a mononeuropathy, so pathology of one nerve? Is this a mononeuropathy multiplex where there are multiple individual nerves? Or is this a polyneuropathy where there are nerves affected kind of throughout the body? So I'm trying to think that this is the left hand and the left foot. So that's interesting to me because it seems like it's more than one nerve that's affected. So is this a mononeuropathy multiplex or is this a polyneuropathy? And I think there's, after we figure out the localization, then you can think about the differential. Is there a metabolic derangement that's causing this? Is there an autoimmune process that's causing this? Any toxin exposures, or is this kind of with the acute time course, has there been some vascular issue like a stroke? So those are the things that are running through my mind. Ravi, what's going through your mind with this chief concern?
I'm just so impressed how you were able to sort of superficially tackle this complaint here, and just diving into the neurological causes, and then sort of tapping into the neuroanatomy that we all learned in med school to try and maybe get the ball rolling and trying to figure out what is the problem here. So you actually hit all the keynotes. I don't think there's anything I would really use time on, because this is an iterative process where we need more information to see if this is a neurological condition or is this a systemic condition. So is this paresthesia part of maybe another maybe syndrome, metabolic syndrome, endocrinopathy? Is there maybe something toxic that could be causing this sort of presentation? So I'm not too sure right now if there's a primary neuropathy or neurological process at this point. So I think the next aliquot may actually give us some more clarity in what we're trying to define here. So I mean, this could even be something as routine as diabetes, which can manifest with different sort of sensory impairment or paresthesia. So I think we'll move on to the next aliquot. Or is there anything else, Maddie, before we move on?
No, I totally agree that we need a lot more information. I think the other thing that I'm just struck by is that it seemed unilateral. It's just that it's only on the left side. I'm not quite sure how we can make progress on that, but that's just something that struck me as something that is perhaps important, but I'm not quite sure why it will be important.
Okay, I'll start. So, history of present illness. 2 days ago, a patient went out for a dinner. She felt hot flushes, sweating, and lightheadedness, and she passed on her dinner chair. She lost consciousness for 20 seconds, and she was noticed to have jerky movements in all her limbs. After 20 seconds, she recovered on her own. She does not report having any headaches, confusion, or tongue biting after the episode. Next morning, on waking up, she had pins and needle sensation in her left hand and foot. The sensations were present throughout the day and got worse while walking. On review of system, there was no history of any seizure, no headaches, no palpitation, no diarrhea, no abdominal pain, no shortness of breath, chest pain, or any weakness in body. Patient had a history of intentional weight loss of 30 pounds over 1 year by strict diet control and exercise. I'll stop here.
Wow, Ravi, do you want to go first on this one? Or do you want me to
Sure.
continue?
I'll kind of just maybe talk a little bit here, but the gist I'm getting from this HPI now is you have this maybe a vascular cause of this presentation here, with this patient having these hot flashes, lightheadedness, maybe a cerebral vascular process going on. I maybe not say TIA, but this patient appears to be having, should I say pre-syncopal, suffered hot flashes, lightheadedness, but there's no loss of consciousness. But then they're still having these paresthesias. So there's loss of, I guess, nerve, what do you say, with the peripheral neuropathy, you either have a positive sensation like pain or paresthesia or dysesthesia, or you have a negative thing like sensory loss here, but patient doesn't have sensory loss. So they're having like either a hyperactive neurological process, like the nerves are hyperactive and you're getting these numbness and then tingling, and then this lightheadedness just introduces another process where there could be a cerebral vascular process that may be going on. Still, I don't know what the problem is. Is it I would be concerned with this lightheadedness, and it was self-resolving. We could easily say it was a seizure, but lack of tongue biting, that gives actually, I think, a good positive predictive value, and the lack of it, a negative predictive value. So likely to be a seizure. And there still is this abnormal sensation that I'm kind of worried about. I like that you had honed in on this unilateral process. So usually when you have a systemic process, it should be bilateral. So unilateral makes it more localized to maybe the spine or peripheral nerve. But I'll probably land my plane there and maybe have you talk about this, or if any thoughts are coming across your mind with these constellations as signs and symptoms.
Yeah, Ravi, I really very similar to you. I'm trying to figure out what is the problem that we're trying to solve here. And it's interesting that that what Navpreet talked about that happened 2 days ago, where it seemed like there was a transient loss of consciousness that involved jerky movements, and as you said, was self-resolving. And we've talked about transient loss of consciousness a few times on VMR, and some of the big things you think about are seizures, syncope, hypoglycemia, or a stroke. And so if we're trying to figure out, well, which one of those things could be going on, I think you can think of like some helpful way to clarify which of those options it is, to think about what happened before the loss of consciousness, during and after. And I think the fact that there were jerking movements during it, of course, makes you think, okay, well, is there a seizure? But exactly as you said, some of the things that you would also expect to see with a seizure is kind of this post-ictal phase and tongue lacerations, which I don't think were present here. Definitely no tongue lacerations, and I'm not sure if there was a post-ictal phase. And I think the hot flashes and the lightheadedness preceding, could that be this like an aura? Or could that be more consistent with like a pre-syncope, kind of the symptoms that you have before vasovagal? So I think the takeaway here is that I'm not entirely sure what the loss of consciousness represents. Does it represent syncope, or does it represent seizure? Those are my two thoughts right now. But it's also interesting that it seems like this numbness and tingling started after this loss of consciousness episode. So one of the things I'm trying to tease out in my mind is this related? Is the numbness and tingling that the patient is experiencing a result of something that happened during this loss of consciousness episode, or is it unrelated? So a lot of really interesting pieces of information here. I'm not quite sure what is the center of gravity yet, so I'm hoping to see if maybe the past medical history and physical exam will help to clarify that.
Oh, yeah. While you were discussing this, Maddie, a couple of highlighted points actually popped up, I guess, in the red. So I think I missed there was actually loss of consciousness for 20 seconds. So this was like a syncopal episode. Now, what's interesting, while you were mentioning it, triggered a couple of thoughts. And remember, we started down down the road of possible CNS disorders like neuropathies, peripheral neuropathies, and so on. But there's not many neuropathies that would cause loss of consciousness, right? You should have the numbness, tingling, loss of motor function, sensory function, or hyperfunction, and then feelings like burning and cold and things like that. But the loss of consciousness does make it, or does prioritize the CNS or central nervous system, upper central nervous system, I think, at this point, because the loss of consciousness means that there may be transient loss of blood flow to the brain. So then you have to start thinking of cerebrovascular causes. So what could cause that? Again, we went through maybe risk factors for TIAs or syncope. Could it be a cardiogenic cause? Could it be a neurologic cause? You aptly talked about the vasovagal conditions. You do have this hot flash, lightheadedness, and kind of dramatic and tingling, and usually you can get that with a vasovagal episode. But I would look for, in a 50-year-old, I would look for repeated episodes, which would happen rather than just the one-off episode. Is kind of ought to have it just now, and it is a diagnostic exclusion. So I would put that lower down in my list of potential hypotheses, and then put the more threatening conditions like TIA or syncope due to maybe a neurologic or cardiogenic cause, or you could put other causes like obstructive issues like PE. But I guess any other thoughts before we move on to the next aliquot?
No, that was brilliant thoughts. All right, Navpreet, back to
Yeah.
you.
So for the past medical history, patient had a similar episode of passing out 1 year back while she was taking a shower, and she recovered on her own, and she does not consult any doctor at that time. She had a history of umbilical hernia, which was repaired last year with no post-op complications, no history of any diabetes, hypertension, asthma, or allergies. Social history, patient does not smoke, no drinking, no use of any illicit substances. She had a normal menstrual history and had 3 kids delivered through C-section. Family history, patient had a mother had a history of heart disease with valve replacement at the age of 75, and father had a history of colon cancer. I'll stop here before.
Yeah, I do you want to go for it, Ravi, or should I take
Oh
this one?
no, I was going to say you start with this.
Okay. So I think what's really key here is that this is that her syncopal episode that happened 2 days ago is not the first time this has happened. So I'm kind of framing this as recurrent. Recurrent, I'm not sure if I should use the word syncope, but there's like a recurrent symptom here. And the question is, what is the trigger? And if there's like a consistent trigger. So it seems like 1 year ago, she was showering when this happened. And this time when it happened 2 days ago, she was having dinner. So those seem like two different triggers. So I'm wondering if it's just interesting that this loss of consciousness episode has happened twice with different triggers. I'm wondering if there can be some similarity between showering and sitting down having dinner that was causing this. But oh gosh, I feel like I remember hearing like showering, loss of consciousness when showering should be associated with something, but I'm kind of forgetting now. It kind of seems like a vasovagal picture. But I think, Ravi, I'm curious, like what showering and having dinner, like, is there anything that's in common there that could lead to syncope? I'm curious how you're thinking of that.
Maddie, first of all, I want to commend you on really being able to extract the salient features of this case. And exactly, I was picking on those things. And it kind of odd, like patient had syncope before, especially with the hot shower. So you're raising a valid question. And I think that actually could be the turning point in us trying and possibly solve this case here. But I want to be kind of frugal at this point with my thoughts, because maybe it'll lead us down the wrong path, I would say. But it actually poses a very interesting question, like what would heat do? But remember back to medical school and physiology, I guess physiology 101, that heat could actually cause vasodilatation, right? So in the body, when there's a lot of heat, there are a couple of heat related injuries or illnesses that can happen, heat related exhaustion, heat related syncope is one, and then heat related cramps you could get, skin disorders as well. So physiologically, heat could cause vasodilatation. Your body's trying to get rid of the heat, and when you vasodilate, you could vasodilate to such a degree that then you just pull all your blood into the lower parts of your body, and so you could syncopize transiently. There is other things that kind of heat can do. I think heat can also cause mast cell degranulation. I think that could also be a heightened sort of hypersensitivity reaction. I'm trying to think back. There is also a heat-related chest pain that can happen. Although this patient doesn't have chest pain, I'm going to have to look that up. But I remember there is a condition where you can get a hypersensitive reaction causing this. And then I think it's just possibly the heat causing this vasodilatation. It's very odd that it happened around that time. Postprandially, though, I like, if many of you around, if it's lunchtime for you, you all have probably had a meal, hopefully, and that's causing you to have some postprandial lethargy. And in some patients, they can have syncope, just like micturition syncope. that can happen as well. So all your blood flow tends to go to your splanchnic circulation, and that could then cause syncope. So I think these are really important points that could actually pivot us towards a possible condition. So what could set you up for syncope? Taking a shower. Maybe you have some volume depletion. Maybe you have some autonomic dysfunction, something that could be secondary to a condition. Syncope, we've had the most extreme cases. Even I had a case presented with one of my residents that was a patient with amyloidosis. We've had amyloidosis a number of times with a patient coming in with syncope. It could be something as routine as diabetes as well, which could cause autonomic dysfunction. So a couple of things to think about, but I don't think we have the whole case revealed to us yet. The family history here, there's a valve replacement. Maybe the physical exam will give us a clue. Other heat-related things that I would think about, hot showers, and you get aquagenic pruritus, right, with polycythemia vera, although we're not getting that kind of a flavor here. And then hot showers with cannabinoid hyperemesis syndrome, that would be alleviating. Again, we're not getting that sort of a signature here, but I'll swing it back over to you if any other thoughts cross your mind while I was rambling on.
No, I absolutely love that. And I think, if we are framing this as syncope and like recurrent syncope, which I think is at least the temporary frame that I'm using, I like how to think about it in like pathophysiologically. So syncope being transient decrease in blood pressure, then thinking about, is it low cardiac output or low systemic vascular resistance? And I think right now we're thinking this is like a problem with low resistance, and between both the meals and shower, maybe there's an increase in parasympathetic tone causing the vasodilation. So that's kind of one way we can be framing this right now, but I'm interested, like, why all of a sudden is this happening now to her? How is the numbness and tingling related? So those are some unresolved questions in my mind right now. So yeah, those are the thoughts I have.
Mengu actually posed an interesting sort of concept as well. Uthoff's phenomena, I kind of forgot about that, but there's a transient worsening of neurological symptoms related to demyelinating disorders such as MS when the body becomes overheated in hot weather. So that could be something as well. Although epidemiologically, 50-year-old, it could happen. But again, this kind of takes us back to the neuropathies or this paresthesia and so on. That could be the clue that there could be a systemic demyelinating process that's going on, but I would look for other things. Maybe that's the thing that could tie it into that. But back to you, Navpreet.
For the vitals, patient had a temperature of 97.8. Her blood pressure on arrival to the ER was 178 by 114, pulse of 75. Patient is maintaining saturation of 96% on room air, respiratory rate of 18. Physical examination, patient is resting, awake, and alert with no acute distress. Heart, TNT is normal, bilateral xanthelasma present. Cardiovascular, respiratory, and abdominal examination is normal. Extremities appear normal with no edema or calf tenderness. On CNS examination, patient bulk, motor strength, and reflexes are normal. Patient has a normal gait, no weakness present in anywhere in the body. Romberg test was normal, no Babinski sign. All cranial nerves were intact and normal. Patient has pins and needle sensation in the left hand and foot, but no other sensory abnormality throughout any part of the body. I'll pause here.
Oh, wow. Maddie, you want to take a stab at this?
Yeah, so I think there are some pertinent negatives here. So I think going into this exam, I was thinking that, the problem that we were trying to solve was this recurrent syncope. And then we also had this piece of neuropathy in the left hand and the left foot. So I was really kind of interested in the neurologic exam. And the neurologic exam is consistent to what the patient was reporting, this pins and needles in the same exact location that she was saying. And as I talked about in the beginning, I was trying to think, is there some mononeuropathy multiplex, or a polyneuropathy? And I believe I would be framing this as a polyneuropathy because, more than one is involved. It's helpful that there's no motor deficit. So it seems like it's just limited to the sensory abnormalities. And I'm trying to think if, let's see, like I think from Aaron Berkowitz, I'm trying to remember, he's framed neuropathies as is this axonal or is this demyelinating? And I believe the axonal ones are the ones that are length dependent. So that's when the neurons, like the longest neurons, are involved first. So the ones that go to the toes are first involved. And that's not what we're seeing here because it's only on one side. So I'm wondering, is this more of a demyelinating neuropathy? But I'm a little bit stumped here, but it's just interesting that there's no additional data in the physical exam that we didn't have from the history. So I think just getting some basic lab work from here is something that would be helpful to see if there's like an additional systemic signature to what's going on. But I'm curious, Ravi, what are you thinking at this point?
Oh, before I dive into this, I just want to say it's just awesome hearing you wax lyrical about the exam and the neurological features of this case. So we've come a long way from the case we discussed a long time ago. Remember that the neurological case that we had that had us stumped. So I think you're back with a vengeance, and you want to take on neurology. So
Ravi,
neurophobia.
I think it's a rule we can only discuss neuro-related cases together.
Yeah, I was about to say when Navpreet mentioned the first aliquot, I was like, oh, it had to be a neuro case.
I know.
But yeah, it's interesting here. First of all, the blood pressure, was it 178 or 140?
It was 178 by 114.
140. So yeah, this blood pressure really stood out to me. 114. Okay, this is excessive, and you have to start wondering: is this symptomatic hypertension bordering on an emergency? Is there end organ damage with this? So definitely, this raises a suspicion if this is having any weight on the CNS system. Other areas, when you do an exam, you want to look for papilledema, you want to look for cardiac effects. ACS could be one. It could even, with this pressure here, you could even have a microangiopathic hemolytic anemia, acute kidney injury as well. And if there's any vascular issues, an acute vascular catastrophe like aortic aneurysm, rupture, or dissection. So we have to be really careful here. Patient could also have altered status with a large pressure like this and maybe rupture of a berry aneurysm. So this plus the neurological features of this case has me a bit worried. Again, we're not getting weakness like Madalena had astutely mentioned. So we're just getting these pins and needles. But previously I talked about maybe a vascular issue, though with the vascular issue, it usually is transient unless you have a complete occlusion of a vessel. You may lose sensation, but then you look for other features. Maybe there's discoloration in the extremities. Maybe there's also swelling of the extremities, which we're not seeing here. So this makes me more concerned about a neurological condition. Maybe the blood pressure is due to this systemic process that Maddie had mentioned earlier. So you can have autonomic dysfunction. Blood pressure could just skyrocket and you're not able to regulate the blood pressure. Usually when you have a high blood pressure, you have a certain number of regulatory mechanisms that kick in. Your kidney senses it, you diurese, then ANP increases, that also augments diuresis. So you have a couple of reflexes intrinsic to the body, and a fully functioning normal kidneys should be able to regulate somewhat of that blood pressure. But this has me kind of concerned. And I think the labs may actually shine some diagnostic clarity on this process. So we'll move on to the labs. Back to you, Navpreet.
Yeah. So for the lab for the patient had a hemoglobin of 13.4, MCV 88.9, platelet count of 229, glucose 110, sodium 139. All other electrolytes are normal. Renal function tests were normal. Liver function tests were normal. We did a CT head on the patient. It came out to be normal. We do CT angiogram to rule out any cardiac stenosis. It also came out to be normal. Lumbar puncture was done on the patient and results are pending. And I'll stop here. Then we'll see. EKG was normal as well on the patient.
So I guess most of the chemistry was normal, right?
Yes, yes, sir.
And troponin was normal.
Yes.
So we're given just the hemoglobin and the MCV. So there's no anemia here. There's no polycythemia here. White count is normal. So we're not going to think about infection, or maybe if the white cell count was in the upper 30,000, 100,000 range, maybe a leukemia. But I'm not getting much from the labs here to really help us narrow down our hypothesis at this point. What do you think, Maddie? Does this do anything for your differential that you had, the list of differentials?
Yeah, I mean, I think all pertinent negatives. I think I'm reassured that there's not a clear systemic signature here. We talked about how some metabolic derangements can contribute to neuropathies, and we're not seeing any obvious ones, so that's helpful. We also talked about how with kind of an acute neurologic process, like this happened that one day, we're concerned about a vascular event, and so the normal head imaging is really reassuring. I think with all of this, and Navpreet said that there was an LP pending, I'm thinking back to the fact that this has happened this seems like the second time, and I haven't reviewed multiple sclerosis so much recently, but I remember that you can have these signs and symptoms disseminated in space and time. So I'm wondering if that's just like a differential on my mind right now, especially I believe maybe I'm forgetting kind of the epidemiology, but for some reason I'm thinking like, does a middle-aged woman, does that epidemiology fit? And so I think there are a lot of pertinent negatives, and I'm just trying to think what could be causing these intermittent syncopal episodes with like a neurologic signature. And MS just like comes to mind as one that can have these intermittent symptoms. Yeah, but anything else on your mind, Ravi?
Yeah, you're bringing up an interesting point about MS, and this does actually seem like, I mean, epidemiologically 20 to 30-year-old female, but it's not uncommon to have it into the 50s. This numbness, tingling, this sort of polyneuropathy you mentioned, this may actually be an indicator that multiple sclerosis, maybe one of the first presentations of multiple sclerosis. And then the hot flashes, I guess there's some sort of autonomic feature to this too, which also can be seen in multiple sclerosis. And then the blood pressure, autonomic dysfunction is kind of interesting here. But yeah, I don't have anything to really pivot on to say like it's this, but I think we have a couple of thoughts, right? So is this something that's inflammatory, autoimmune, and vascular, I guess, imaging? So if we're not sure what we're dealing with, definitely doing further diagnostic testing. The LP will be helpful, looking at the cell count, looking at the protein level, looking at white cells, see if there's inflammation in the spine. Imaging of the spine as well would be helpful. Is there something like a transverse myelitis or something that maybe MS, and looking for the typical sort of features of MS on a head, on a MRI of the head. These would be very helpful, I think, at this point. But anything else before we move on?
No, I'm right there with you.
Okay, a very interesting case, Navpreet. Yeah, it's got us really thinking. But it's a fantastic case and great way of presenting. I mean, you're presenting it really well. For your first case, I'm just amazed. I remember I made a mess of my first case when I presented, but you're doing a great job.
So
I just have to echo. Oh,
Yeah,
Navpreet,
go
I
ahead.
just wanted to echo Ravi that you're doing a fantastic job presenting, and both Ravi and I are on the edge of our seats. So really, great job.
Thank you. I just want to ask from the team and all of the like, what are our top differentials? Because the next result's gonna give us the answers, the final diagnosis. What do you think are the top differential on this case?
Yeah, it's you wanna try, Maddie?
Well, so I think it sounds like Navpreet said the LP was pending, right? So I'm assuming that we will get the differential from the LP, or maybe there's some additional imaging. And I'm trying to think what I think multiple sclerosis is, maybe I'm like anchoring too hard on that. That's high on my differential. I'm not, what else is on your differential, Ravi?
Yeah, if you're mentioning, okay, the LP is going to give us the diagnosis, but what are the things just from a superficial view of the LP? We usually look at protein, we
Yeah.
look at cell count, we look if there's pleocytosis, neutrophilia. If we look for glucose, then you can diagnose meningitis, encephalitis between those. Then you need to do specialized testing looking for the oligoclonal bands and looking for maybe autoimmune antibodies as well. So that would need a next level testing. So if we're looking just superficially at the cell counts, I'm not getting any flavor of any meningitis or encephalitis. Maybe you can diagnose head bleed as well, subarachnoid hemorrhage. You could look for xanthochromia. You can look for a large amount of RBC. So those are a couple of thoughts that crossed my mind. With the blood pressure, I was thinking initially maybe a stroke, because a compensatory process of stroke is to make sure you can perfuse the ischemic penumbra, and you will have this reflexively elevated high blood pressure. But I doubt we're in that domain, but the answer may lie within the CSF and the spinal cord. So those are sort of my early sort of thoughts there, but I'll pass it back to Navpreet to reveal what the CSF shows.
Yeah, so I got hold of this case when I was doing my observership at St. Peter University Hospital, and the patient was really stressed out. She was really pissed because when we were going there, every medical student residents, we all were going and asking if you had any weakness or any hypertension and all. And she was really concerned about her numbness. And she one time she also yelled at us, like she was like, please help me with this numbness. This is actually bothering for us. So we did an MRI on this patient. MRI shows periventricular white lesions foci around corpus callosum and with demyelination at the level of C2 cervical spine. MRI angiogram shows no signs of dissection or stenosis. That was the only imaging, that was the only positive result that we got in this patient. And after we did the diagnosis, the patient was before that our team was thinking of some stroke or some TIA, and she was on aspirin, antihypertensive, and all. She was that thing was not helping her anyway with her numbness. And when we did the MRI, we got the diagnosis. We start the patient on methylprednisolone, 100 microgram for 5 days, and right after the first dose, her numbness was like 80% gone. And that was the case that we had on the hospital.
Wow. We've had a number of MS cases, but it's so funny. I presented a case of a patient with tumor factive demyelination. So you have these tumor-like, MS can present with these tumor-like configurations within the MRI in the brain. So that's just amazing. Usually, every time we've had MS, it's usually this may not be symmetric sort of numbness and tingling, which is kind of odd, but you can't really assign it to a specific disease. But early on, Maddie did a great way of framing the case with the sensory problems, and many times on VMR, sensory problems could be MS. So I think I've been taught MS again. How about you, Maddie?
Yeah, I'm kind of speechless right now. This was such a interesting case to think through, and Ravi, just so much fun to discuss with you. And yeah, there are a lot of, I want to do more reading on MS because I don't think I have a robust illness script of it. Like, for example, I know like optic neuritis is a common presenting symptom, but it seems like this patient didn't have that. And I'm curious, Navpreet, if you could like how was your team thinking about the recurrent loss of consciousness episodes? Like how were you tying that in, and how was that related to the MS in your mind?
Yeah, that's actually a good question. So the first time when the patient came to our ER, she didn't even specify about the episode of loss of consciousness that she had 1 year back. So I went to her again, like to talk to her, like if she had these symptoms before. So she opened up about this episode, and she was taking on hot shower at that time, like 1 year back. And the loss of consciousness that she had at the restaurant, she told me that the restaurant was really busy. There were like a lot of customers. The benches were, she was like kind of feeling hot and all, and like basically that there was a high temperature that triggered her symptoms. So that's called ortho phenomena. So that was the like hot shower and all was triggers her MS. That was
Wow.
what we were thinking.
Wow.
So the chat was on fire with the Uthoff phenomenon,
Yeah.
with the hot shower. So interestingly, the blood pressure, I was trying to find if that was a pivot point, or not a pivot, but one of the points which could pivot us towards multiple sclerosis. And there is an association, because that blood pressure is just so ravagingly high. And in a patient that doesn't have a past medical history of blood pressure, high blood pressure, no, right? So she's never had a history of hypertension before. Is that right, Navpreet?
Yes, there was an undiagnosed hypertension. She didn't know that she had hypertension, and after we put on the medication, her blood pressure came out, dropped down to the normal value.
So interestingly, there's a 25% more common association of high blood pressure with MS. So something to think about next time. So great. Thank you very much, Navpreet, for putting, I know it takes a while to do this, so I appreciate you putting in the effort to bring such a great case and teach us MS all over again.
Thank you. And I do want to thank you, Dr. Reshma, for helping me portray this case to present to the team. She did a great job and helping me out.
Woohoo, Reshma, good job. Thank you.
Yeah, thank you so much again, Navpreet. I'm going to be reading about multiple sclerosis and what is the phenomenon? Uthoff phenomenon.
Uthoff phenomenon.
Yeah.
There's the other one, the Lermet sign, right? When you bend your neck and you then just trigger the sensation down the spine. So there are a couple of signs that are associated with MS.
Yeah. And then I guess before we pass the mic to Gia, Navpreet, one quick question. So the second episode with the jerky movements, was your team thinking that was a seizure, or how were you thinking about the jerky movements there?
Definitely, we were thinking on all the perspective of seizure, because she went to dinner with her son. So the son was like shiver all over the body and all, like a little confusing, but definitely it was not seizure because there was no confusion. She doesn't have any headache after that, no tongue biting, and she said that I came out of the restaurant, take a deep breath in the fresh air, and after that she was feeling fine. So that was kind of, we rule out the and I guess we also did, no, we didn't do because there were no signs of stroke or seizure. So that's how we rule it out.
Got it.
And it was like a dead end, like she doesn't have any positive history. She was not giving any other clue than just pins and needles. And that was troubling her all over. Like she was so upset that she was like, either help me or like send me somewhere else. It was that bad. And the medicine did magic too. Like she just got one dose and that's it. She was like back to normal.
Oh, well, so happy she's doing better. All right,
And
Gia. Oh, go ahead. Sorry.
Sorry. And because the lumbar puncture takes 5 days, 5 days for the results. Because after we did the lumbar puncture, she was sent back home. And when we talked to her again, her lumbar puncture came out with positive for oligocondylar bands too. That's all. Thank you.
Wow. Thank you so much. All right, Gia, we'll pass the mic to you for teaching points.
Okay, thank you so much for this great case, Navpreet, and thank you so much, Ravi and Mandy, for this amazing discussion. And so today, according to the problem represented from Amanda, today we have an elderly woman complaining of numbness and tingling of left hand and feet. And the patient actually suffered hot flash, lightheadedness, loss of consciousness and jerky movement at the same time. And similar symptoms happened 1 year ago where the patient was in showering. So the things we got today, what we learned today is first, considering of sensory complaint, we need to consider the whole pathway from the peripheral nerve to the surrounding tissue and to the CNS brain. And we need to think about the localization and team cause. And like the unilateral and bilateral symptoms can also help us to localize the lesion. And then we talk about some things we need to think of when thinking peripheral neuropathy, like whether it is manual neuropathy or polyneuropathy. And for the etiology, we can think about toxicity or autoimmune disease, vascular disease, or any metabolism symptom factors. And then from the history of present units, we learn about the patient has loss of consciousness, which concerns us a lot of the hypercNS lesions. And we discuss further about the seizures and the syncope. First, for the seizures, we can think about the pre-symptom, post-symptoms, and the patient's symptoms during the course. Like some positive symptoms like pain, numbness, and also some negative symptoms like sensory loss can happen as well. And for the post symptoms, like some more typical symptoms like tongue bite, incontinence, or confusion. And for loss of consciousness, we should also think about some vascular etiology like TIA, pre-syncope, syncope, vasovagal episode, especially this patient complained of hot flash and lightheadedness. And then the past medical history revealed that actually this patient is her second time of such symptoms. And also, she mentioned a very interesting trigger that her symptoms happened during shower and having dinner. Therefore, we discuss like what the heat can cause. Like the heat can cause vasodilation and then further contribute to low blood pressure. Like some cardiac condition and systemic vascular disease can put the patient's fragile condition to more likely have low pressure. And also, heat can contribute to autonomy, dysfunction, exhaustion, and appear as chest pain, and also muscle cramps, and a very interesting phenomenon called Ostov phenomenon, which is related to the demyelinating disorders. And then from the physical examinations, the patient's blood pressure is very concerning. And then we discuss hypertension urgency and emergency, like whether some major organs were involved in this course, like CNS, cardiac, heart, kidney, or is there any encephalopathy? And then because from the labs, we didn't get any significant positive labs. And considering the patients have these 2 episodes and like different appearance, including the numbness and autonomy dysfunction. Therefore, we talking about more about the multiple sclerosis. And finally, the MRI help us to reach to this diagnosis. And we also discuss a little bit about how the loss of consciousness can relate to the multiple sclerosis, and more about the autism phenomenon. That's all I have today for this VMR. Thank you, everyone.
Oh, awesome job, Gia. You were able to catch all the important points and features of this case. So it was interesting revisiting all the thoughts that we had. And Maddie, great catch on the MS. You definitely nailed this case here. And early on, you had the thought of MS. So we did it this time we tackled the neuro VMR. So Congratulations. Look forward to the next time.
Yeah, I always love discussing with you, Ravi, and only neuro cases for us going forward. And Navpreet, again, thank you so much for this fantastic case presentation, truly expertly presented, and I hope you present many, many more in the future. And
Thank you.
Gia, fantastic teaching points. That was so organized and well summarized. So great job.
Thank you.
Thank you, everybody. Have a great rest of the day. Bye.
Bye.
A good day. Bye.